Hi everyone. So today I'll be talking about the evaluation of dysphagia. In particular, what I'll be talking about is the differential, the diagnosis and treatment of dysphagia, and it's going to be pretty brief, so it should be helpful for anyone studying for any of the NBME shelf examinations. So before I go actually into the differential for dysphagia, the first thing I want to talk about is what are some important questions to ask. Say you have a patient who comes in, what are some things that you want to make sure you touch up on? So the first thing I always recommend starting off with is ask the normal set of questions you tend to ask any patient, including the onset characteristics, time course. Use any mnemonic you find helpful when you're talking with patients, and ask those set of questions. Along with that, some other additional questions I recommend asking is how long the dysphagia has been going on for. And I feel like the reason that's important is for patients, say a patient reports that they've only had dysphagia for the last, um, say a patient comes to you and they tell you that they've had dysphagia for the past 10 years. I think in that situation, something like esophageal cancer might be lower in the differential. So that might be a good question to ask. Along with that, I think it's very important to also ask about whether dysphagia is to solids, liquids, or both solids and liquids. The reason that's important is if someone has dysphagia to both solids and liquids, I'm thinking more of a motor issue. Whereas someone who has dysphagia to just solids, I'm thinking more of a mechanical issue. Next, it's important to ask about the presence of any concerning symptoms, in particular weight loss. Weight loss in particular might make you more think of something like esophageal cancer. Next, it's also important to ask about any associated symptoms like heartburn, which might make things such as esophageal strictures more likely. Lastly, it's a good idea to ask about risk factors, including a history of GERD, which once again might make something like strictures more likely. It's also important to ask about alcohol and tobacco use, which might make things like esophageal cancer more likely. So now to get into the meat of the presentation and talk about differential diagnosis. So the thing that I highly recommend to anyone who has a patient with dysphagia is to think about it in two major categories in terms of what can be causing it. One is motor issues, and the other is mechanical issues. So in motor issues, it includes things such as achalasia, scleroderma, and esophageal spasms. So to briefly talk about each one of them, achalasia is a motor issue where essentially the lower esophageal sphincter, which connects the esophagus to the stomach, becomes very tight and it prevents things from moving through. So that's why in imaging, one thing that you tend to see is a classic bird beak experience. That's something, if you haven't seen it before, definitely look it up. So once again, achalasia, the major thing to remember is a motor issue which prevents things from getting into the stomach. Next, scleroderma. So scleroderma is an autoimmune condition where essentially you have fibrosis throughout your body due to deposition of collagen. So one potential place that collagen can deposit is in the esophagus. And up to the statistic is somewhere like 90% of the patients who have scleroderma can also have some sort of GI issue. So when this for these patients with scleroderma, when this collagen does deposit in the esophagus, essentially you have poor movement of the esophagus, which leads to dysphagia. Next, you have esophageal spasms. So the best way to think about this is in normal functioning esophagus, you have these peristaltic waves which allow you to take food from your mouth down to your stomach. In esophageal spasms, essentially the muscle in the esophagus are contracting in this asynchronous fashion. And as a result of that asynchrony, food isn't able to move down properly from your mouth to your stomach, so you have the dysphagia. So those on the right side are all the motor issues that we've already talked about. And on the left side, we have some mechanical issues that can also lead to dysphagia. The four ones that I think are important to think about it include stricture, cancer, esophagitis, and esophageal webs. With regards to stricture, it's essentially any narrowing of this, or any narrowing of any portion of the esophagus. One thing that in particular this can be due to is symptoms of gastric reflux. When those some of those acidic contents reflux back into the esophagus, that can cause narrowing of the lumen, which leads to in turn leads to stricture. Next, it's also important to think about things such as esophageal cancer. This is in particular important in patients who have a long history of smoking or alcohol use. The other key thing I would recommend knowing about esophageal cancer is it comes in two varieties, adenocarcinoma and squamous cell carcinoma. Adenocarcinoma is more common in the caudal end of the esophagus, and then squamous cell carcinoma is or sorry, I should yes yeah. So just to reiterate that one more time. So with regards to esophageal cancer, adenocarcinoma is more common in the caudal end, and squamous cell carcinoma is more common in the cranial end. Next, we have esophagitis, which refers to any nonspecific inflammation that happens in the esophagus. As a result of inflammation, you can imagine there's narrowing of the esophagus, which in turn causes dysphagia. With regards to esophagitis, can be due to a variety of different things. You can have eosinophilic esophagitis, which tends to be common in, say, patients who have other eosinophilic issues such as asthma. You can also have pill-induced esophagitis, which I believe bisphosphonates can also cause that form of esophagitis. So essentially a variety of different things that can cause this inflammation, which in turn leads to dysphagia. And lastly, I also included esophageal webs. So this is something that you can see in conditions such as Plummer-Vinson, which has esophageal webs, and iron deficiency anemia. Another thing to think about when you're thinking about your differential. So the key thing, once again, that I want to emphasize is that any patient who comes in with dysphagia, you want to think about whether it's a mechanical issue where it's due to blockage of something in the esophagus itself, or if it's due to a motor issue where essentially it's due to some sort of it's due to this dysfunction of the muscles themselves that leads to dysphagia. And just thinking from that perspective, I think will help you tremendously when you're evaluating a patient. So next, the question becomes, what additional testing you want to do you want to do on a patient who has dysphagia? And I included CBC here, and this is something that that you may or may not want to do, and I can mention why you may want to do a little bit later. The three key tests I want to emphasize is doing the barium esophagram, endoscopy with biopsy, and esophageal manometry. So starting with a barium esophagram, essentially pretty straightforward. Patients swallow barium contrast, and when patients swallow the barium contrast, you can actually see it going down the esophagus, and as you see the barium going down the esophagus, that will allow you to see any strictures that are present, will allow you to see any narrowing. But the issue with the barium esophagram, as you can kind of guess, is that it allows you to see narrowing within the esophagus, but it doesn't allow you to see what's causing it. So for instance, a patient on a barium esophagram could have a narrowing at the distal end of the esophagus, but you're not going to see what it is. So it could, in theory, be due to cancer, it could be due to a stricture, it can be due to a variety of different things. But nevertheless, barium esophagram is a good first test that you always want to start off with, and it gives you understanding of what may be happening with the patient. And then the other thing I would also quickly point out is on a barium esophagram might also be helpful for certain motor conditions such as achalasia, where essentially what you're going to see is this bird's beak appearance, where on the lower esophageal sphincter you see this narrowing of the contrast material because there's very high tone at that region. So after you get the results of the barium esophagram, one thing you might see is there's essentially narrowing at a section of the esophagus. So normally what you want to do next, and in most situations you want to do endoscopy, and then you may or may not do a biopsy. And essentially upper GI endoscopy, a GI doctor puts a scope down the esophagus and allows you to directly visualize the walls, and allows you to directly see what may or may not be there, including whether patient has stricture or cancer, and allows for direct visual confirmation. So once again, for a patient who has cancer in that situation, you might want to do biopsy of it. That will tell you whether it's it's adenocarcinoma or squamous cell carcinoma. But endoscopy is a very valuable tool in evaluation of patient dysphagia. Another test you want to do on a patient who presents with dysphagia is esophageal manometry. Essentially, that's a fancy way of saying you want to look at the pressure waves throughout the esophagus. The reason that's particularly important is patients who have motor issues. So for instance, a patient has achalasia, which is once again the increase in increasing muscle tone at the lower esophageal sphincter. What we'll see on manometry is increase in muscle tone at that region. So it allows you to directly see the pressure at different regions, which allows you to better assess a lot of these motor issues. Lastly, what I want to talk about is treatment. Now, not surprisingly, dysphagia is due to a variety of different causes, so treatment can be incredibly variable depending on the cause. But some of the more key things I just want to quickly go over is treatment for some more common conditions. So for achalasia, the key thing that you want to do is called a Heller myotomy. And so in this, with this procedure, it's a laparoscopic procedure, and essentially you're taking out some of the muscle in the lower esophageal sphincter, which allows you to lower the tone. Scleroderma, as I mentioned, for a lot of these patients, a significant portion of them have esophageal dysphagia, but unfortunately, due to the nature of the condition, there aren't any curative treatments or a lot of palliative measures that you could provide to make dysphagia less likely, but unfortunately there aren't any good treatments available for these patients. For patients who have strictures, once again, I mentioned could be due to a long history of GERD. You want to use dilators. There's a lot of data in terms of whether a patient has uncomplicated versus complicated stricture, how the treatment differs. But the broad brush strokes that you want to remember is for strictures, you want to use dilators. For esophageal cancer, it's usually a multimodal approach, which includes things such as chemotherapy, radiation therapy, and resection of the tumor itself. Next, for esophagitis, as I mentioned, it can be esophagitis can have a variety of different forms, including pill-induced esophagitis and eosinophilic esophagitis. So for that, it's important to find the cause of the esophagitis and then treat that cause. For instance, if a patient has pill-induced esophagitis, you want to make sure you don't give that medication down the road. For esophageal spasms, so I saw a lot of studies looking at different approaches to it, but the two most common things I saw were calcium channel blockers and peppermint oil. So that overall concludes the presentation of esophageal dysphagia. Just one thing to remember is this is something that if you're taking any of the NBME exams, likely you'll see several questions on it. So it's important to be comfortable with this material. And I think that wraps up the presentation.